Hello, good evening, and welcome to another episode of EAO's Just Ask, your monthly live appointment with a leading expert in implant dentistry. My name is Gerrit Heijkoop, and I'm the host of this EAO channel. And in this live video session, we are going to try to answer as many of your questions around our main question tonight. Do I use the same technique to cover implant threads as to cover roots? And our leading expert tonight is joining us live from Paris, Sofia Aroca. Sofia, good evening.
Good evening, Gerrit, and good evening to everyone who is with us.
Yes, there's already quite a lot of people here active in our live chat tonight. We see Katalin from Hungary. We see Helena from Norway.
Great,
we see Per from Norway. Isabella is joining us from Italy. Victor from Moldova. We also had Maximiliano joining us early from Argentina. Jogo is here. So it's a great crowd. It's a live chat. So if you have any questions for Sofia tonight, make sure you use the live chat and submit your questions live. Now, Sofia, for people who have not Googled you, let me quickly introduce. You're a periodontologist who is a very experienced teacher across Europe, but you also gained some scientific fame by your research work into recession coverage, and mainly also your famous paper from 2010, where you introduced us to the modified coronal advanced tunnel technique and showed us how recessions can be covered even in cases where there's not enough tissue between the teeth. So it's a great honor to have you live with us tonight to talk about covering implant threads.
Thank you very much for this really kind introduction, and I am extremely happy to be with you and to share with my colleagues what I am doing in my everyday clinical practice.
Exactly. Now let's get started. Let's do a short question first. So, Sofia, do I use the same technique to cover implant threads as to cover roots? Yes or no?
No.
No, exactly.
No.
So we have something to go deep in. Before we start, I find it interesting to know, do we have an idea of the incidence of implant threads that need to be recovered?
We have very. Do you want me to share or to show some slides?
If you have data on the slides, or just tell us approximately what are we looking at?
Approximately, we do not have too many studies about the prevalence, because the incidence is one thing, but we are most interested in the prevalence of soft tissue dehiscence around implants. The last really extremely interesting study was done by the Complutense team, directed by Mariano Sanz, and they show in a university population, they show that is more or less 12% of the patient, 12% for the patient show soft tissue dehiscence around implants. Therefore, is a very important percentage of our patient, 12%. Yeah, besides, of course, the peri-implantitis problem, we are talking only about soft tissue dehiscence.
Exactly. So it's an important topic.
Even more in aesthetic area. That is, we have to
exactly, because that's where it matters,
exactly.
And that's where we probably make an attempt to cover it as well, and that's what we're talking about tonight. Exactly. To get us started into the topic, one of the key things we need to talk about is a little bit about definitions and wording, because I've learned from you that there's a difference between a gingival recession and a soft tissue dehiscence. Why is it important to make that distinction?
Extremely important because it depends on that definition that what guides our treatment, our way we approach the surgical treatment. And of course, if you want me to, and when we are facing soft tissue dehiscence, we mainly, or I really like to talk about risk factors. And when we are talking about recession around this gingival recession, we must talk about etiological factors, because there is, I think, if my clinical experience tells me that there is, to make that difference is extremely important, because it's really the first way of facing the treatment to have this really clear in mind the difference between the risk factors, of course, which causes soft tissue dehiscence, and there are not etiological factors, because the etiological factors is given by the mother nature.
Exactly. And why is it so important to draw that clear line between either the etiological factors that are merit of the case of the patient and the different risk factors?
Because the risk factors can be, of course, the risk factors must be evaluated, and can be avoided if the evaluation. Therefore, the soft tissue dehiscence around implant must be avoided. Otherwise, and when you are faced gingival recession is absolutely not the same. Even if we have common risk factors or predisposing factors as a phenotype, but we do not face in the same way the evaluation, of course. That's why the definition of these two different factors are extremely important from a clinical standpoint, of course.
Exactly. And well, we are looking for your questions, dear viewer, that you have around this topic. But in the meantime, to get our conversation started, I think you have prepared a few slides to actually make us really visually understand the difference between these factors and kind of make us understand how you, in a clinical situation, look at the different cases and how you classify the different cases. Could you go along and talk us through that?
Yeah. I can share my screen if you want.
Yes, please show us.
Okay.
And in the meantime, I'm reading through the chat. I see a lot of more nice check-ins from Venezuela, from Norwich, UK, from Tunisia even. So I'm glad to have you all with us, and let us know what you would like to know around this topic. So here we see the same divide again: soft tissue dehiscence versus gingival recession.
Exactly, and you see also that the study that I was talking about just a few minutes ago, that where they show in aesthetic zone that in a university population, of course, 12% of the patient present soft tissue dehiscence. And you can see here that I wrote risk factors around the soft tissue dehiscence and etiological factors of the gingival recession. According to my clinical experience, it's extremely important to make that difference. Can you see that the etiological, when we are talking about etiological factors, that they the direct cause of the gingival recession, we talk about thin phenotype, absence of attached gingiva, or dehiscence of the supporting bone, the position of the tooth, the malposition of the tooth. Also, periodontal disease can cause gingival recession, and also mechanical trauma. We have predisposing factors. The predisposing factors are the thin phenotype and the absence of the attached gingiva. The predisposing factors are anatomical factors. And on the other hand, when we talk about, have a look, the risk factors, there is, of course, there is the thin phenotype. We find exactly the same when we are facing gingival recession. The thin phenotype, the lack of keratinized mucosa, mainly the positioning of the implants, the buccal position of the implant, and also the thin or the absence of the bone, a thin supporting bone. And therefore, if you have these main 4 risk factors, you can from the beginning you can really realize that you can. If your evaluation is right, is clear, and if you understand what you are facing, you can avoid, because you can modify. If the patient has thin phenotype, you can modify it. If there is a lack of keratinized mucosa, you can add, because we have several surgical techniques that can help you to augment the keratinized tissue. And even more, not only the augmentation of the volume of the keratin or the width of the keratinized tissue, but also we know really from a surgical standpoint how this tissue can be stable around the implant, because it's the most important thing is to get or to achieve a certain stability about the soft tissue that you build around the implants. And moreover, the implant positioning is a paramount, really, really importance, because it depends if you have a two buccal position or two apical buccal position of the implant. Of course, and even more, imagine that if the patient had this implant position in the two buccally, even plus he is presenting a thin phenotype, and of course, if thin bone, we are sure that this patient will develop a very, very, very nice soft tissue dehiscence. Therefore, that's why we cannot talk about etiological factors and when we are facing soft tissue dehiscence, and to have these two definitions clear in our mind, we know that will be much easier to avoid the soft tissue dehiscence. And,
exactly. So this is where we see, for example, thin phenotype. We see in both lists, right? It's both a etiological factor. Yes, a patient can have a thin phenotype, but as soon as I start to place an implant, it's no longer an etiological factor. It's a risk factor, because I, as a surgeon or as a dentist, need to address the thin phenotype and do something about it before I move on with the implant. That's the key difference that you would like to bring across, right?
Exactly, because as a lot of time epidemiologists often use the risk factors to indicate that is associated to a cause, but it's not really, because if you can prevent, your risk factor can be, therefore you can prevent, but it's only just a little bit of the philosophy beside the clinic, but it is extremely important to clarify that.
Yeah, and the same with implant positioning. Of course, this is something important in the planning phase.
Sure.
But what if I'm confronted with a situation where the implant is positioned either too buccally or in the wrong position? Is there anything I can still do?
It depends, because if it is a little bit buccally position, you can correct maybe only surgically, and that's why we can go ahead in which way we evaluate or we can analyze that situation in order to make simple our clinical work in order to correct that. But it depends. It's really if the implant is really in a very, very, very bad position, extremely buccal or extremely apical, can be extremely difficult to correct. And sometimes that's why I told you that we cannot face in the same way the recession coverage, and as we face the soft tissue dehiscence treatment.
Exactly. And so before we turn over into what to do, and Victor, I saw you 2 questions. He's already thinking about, so what to do when I come across this. Let's first take one more analytical step to really understand this topic. Can we use the same classifications to assess a soft tissue dehiscence around an implant as we can with gingival recessions?
Not really, because when we evaluate a defect, or gingival recession in this case, or soft tissue dehiscence, when we evaluate according to some clinical parameters, clinical references, And that's why but if you want me to show how a little bit of the difference, for instance, you can see here, according to the new classification, the way of the clinician must evaluate the recession defects. We have several parameters. First of all, we have three types of recession according to the presence or absence of interproximal soft tissue in relation with the buccal clinical attachment loss. Okay, interproximal soft tissue loss according to the buccal. Therefore, we have, and we distinguish three different types of recession. And also, we have to now, the new classification give us the possibility to evaluate the soft tissue, not only the soft tissue, the recession, the amount of chitinized tissue, but also the hard tissue, means the presence or absence of the cement-tonal junction, or the presence or absence of non-cariocervical lesion, which means the steps, because and the phenotype itself, and we have these extremely important parameters which not really guide us to choose the given surgical technique, but we evaluate the case, and maybe we can modify the way of treating the patient, because there is not guide for a given surgical technique. I don't know if you can understand what I am telling, but it is extremely important because we have this parameter. And on the other hand, therefore, we have parameters. We evaluate soft tissue and hard tissue, okay, according to the type of the recession. And the type of the recession, presence or absence of interproximal soft tissue. It's extremely important. In order to cover something, we have to have interproximal vascularization. That's why we really focus on that. And on the other hand, there is no, I think maybe a lot of people will not agree with me, but I think one of the best and the most smart, intelligent classification of the soft tissue dehiscence, it was done by Giovanni Zucchelli, and they classified. You have 4 types of soft tissue dehiscence. This classification identifies 4 classes, as I mentioned before, 4 classes of defect according to the position of the mucosal margin, because around the implant we talk about mucosa and not gingiva. But every one of us knows. That's why. Therefore, the position for him, the position of the marginal mucosa in relation with the adjacent teeth, it will be extremely important, and also not only the position of the marginal mucosa, but also the position, the buccal lingual position of the implant, of the shoulder of the implant. Okay, and they identifies 4 different type of, according to what I was telling, and even moreover, they also classify these different identities. They classify according also to the morphology of the papilla, means the interproximal soft tissue, according to the what is interesting from a clinical standpoint, that they not only identify different type of soft tissue dehiscence, but also that, which is not the same with the classification of the gingival recession, that according to him, I'm not telling that is the only way to treat, but is an extremely intelligent guide for the clinician, because they give you, according to the defect, they give you clinical guide. It means the way that you can treat if, for instance, it's the class 1 and subclass A. It means that everything is okay, only thing that the soft tissue recede epically. Therefore, and everything is okay. And just you have to use whatever you want, what a coronally advanced flap technique or a tunnel technique, because you can use both to cover recession. But what is extremely important, and also they or him or his team and Giovanni Zucchelli, they underline what is extremely important, and it's not the same with the gingival recession, that the connective tissue that you place under the the coronary advanced flap or tunnelized flap, the thickness of that connective tissue must be absolutely not the same, must be must be thick as can cover completely the implant thread, because the implant is metallic. Therefore, we have, by transparency, we can see it. Sometimes you have not really a recession, but by transparency you can see, and they can cause an aesthetic problem for the patient if they have gingival smile. But in any event, that's why I like very, very, very much this classification, because it's a real guide for the clinician.
Exactly. So you would really recommend us to go check out the paper of Zucchelli and others, and deepen the classification, because
exactly, and maybe also to invite him to
to the next Just Ask.
Exactly. Yeah.
Exactly, because it sounds like a proper roadmap on what to do in what case.
Exactly.
And I think you made it also very clear on how assessing a soft tissue dehiscence is different from assessing a gingival recession.
Exactly.
Let me throw you a few questions, because we have two active question askers who kind of ask the similar questions as well. Victor Pallery pitched the first one. He says, which technique can be used to treat the exposure of threads of dental implants as a result of excessive muscle traction after implant treatment?
But it is, I think the best one, if it is the case, if you have if it is the case that you have problems with the tension or with the coronary, I think, and I am a person who is doing a lot of tunnel technique, but I think the coronary advanced flap is one of the best techniques to solve that problem. And do not forget the connective tissue graft used must be thick, or we can use also collagen matrices. We have nowadays collagen matrices that can use in these cases that are really recommended.
Exactly. So this, I think, also already kind of answers Ricardo Figueredo's question. He says, which techniques do you use in order to manage the different types? Well, he writes gingival recessions around implants. Well, that's what we call a soft tissue dehiscence, Ricardo. Could you give some examples? Well, you already referred to the Zucchelli classification as a hint in the paper to see the different techniques, but maybe you want to give another example.
We have according to the type of the defect, if there is the type of the defect. For instance, what the literature show us so far, that we can cover without taking off the crown, we can cover what with coronal advanced flap technique or tunnel technique, we can cover soft tissue dehiscence, small soft tissue dehiscence, and for up to 2 millimeters. If there is a malposition of the implant, backali position of the implant, we have to, and that's why I'm telling that is extremely smart, this classification, because when we have a real malposition of the implants, but still can be treated, we can also modify it. Names surgical prosthetic approach, because with not only doing surgeries, and the surgery for him is always the coronary advanced flap with connective tissue graft, but also we modify the abutment of the implants, and we wait 3 or 6 months with the modification, because is extremely interesting approach. Because what is important, I was talking about at the beginning that in recession coverage and implants, if we want to advance on a coronary position, we need tissue interproximally. And if you do not want, you can augment that tissue only by changing the morphology of the abutment, and to leave the tissue express his own potential, and that's why it's important. Therefore, we have also, when you cannot correct really with any surgical intervention, soft tissue dehiscence, you can also submerge the implant, or you can explant, but we do not talk about explantation, but you can submerge. Therefore, you have the one surgical technique, can be the coronary advanced flap with thick connective tissue graft or collagen matrix. We have the surgical prosthetic approach, and this surgical prosthetic approach is mainly combined with the coronary advanced flap. Or we have the submersion. Also, we have the submerge. We submerge the implant, and we also have what we call is the same, the submersion, the decoronation, because we take off completely the crown and we submerge the implants in order to augment and the soft tissue, to modify the soft tissue and to create very completely different morphology of the soft tissue.
Exactly. So that's a step-by-step approach.
Exactly.
There's a question about that from Isabella Rocchietta as well. But before, let me first take Victor's and Ricardo's questions first, because they both would like to know if you recommend any specific methodologies to decontaminate the exposed threads before you start treatment.
It is extremely important to know that we do not work on a contaminated implants. Of course, if this was in contact with the oral cavity, but when you face, you have to be sure that there is no pocketing around, even if you lose a certain amount of keratinized tissue, and that's why we have this soft tissue dehiscence. Therefore, the contamination can be decontamination and not detoxification, because that is also important, because we are not treating an infected implant. We are treating only the implant that was exposed to the oral cavity, and the patient has no periodontal disease, has no other disease. Therefore, the decontamination, and is the right word, decontamination can be just with chlorhexidine or with povidone or with what, because we do not have really protocols, but of course must be clean.
Exactly. So that's good to underline. If you just joined us, this is EAO Just Ask. We're trying to answer as many of our live audience questions with Sofia Aroca. And well, Sofia, you already explained to us that there's the main four risk factors of why these implant grafts might be exposed, whether it's the thin phenotype that you didn't treat, whether it's the lack of keratinized mucosa, the implant positioning, or the thin or absent buccal bone. Those are the reasons that we're looking at, right? And specifically not in the diseased patients as well.
Yeah.
Let me turn to Isabella's questions. It's about timing. She writes, when there is a large frenum, do you eliminate the frenum first and then when it's healed, you perform the soft tissue augmentation, or do you always do both at the same time?
Very nice question from Isabella, of course. No, if there is a large frenum, I go for a frenum, internal frenulectomy, of course, and I use the same since also the fact that you place a thick connective tissue underneath, and there is in the frenum is only mucosa. There is no muscle fibers in it. Therefore, you can really liberate very nicely from the inner part of the flap, and placing under that flap a thick connective tissue, which really stabilize everything in the right place, in a coronal position. Is extremely that is extremely important. But yeah,
exactly.
I do not go for frenulectomy before.
I've also learned, you told me earlier this week that you've also prepared a little case where we can really see how to prevent a soft tissue dehiscence. Can you talk us through that?
Yeah, just okay. Just I wanted, to really show, for instance, to share with you this case. We have this patient was sent to me because of the gingival recessions. Because of the gingival recession, and a lot of my colleagues, they know this case, but it's a really didactic case. Because when this patient, gingival recession, therefore she was really bothered by that from an aesthetic standpoint. And also the 2-1 had to be extracted because of external resorption. Therefore, also you can see that the measure distance of the 2-1 is smaller than on the neighboring tooth. And this patient wanted to have really better aesthetic. And the question was to place an implant, and which will be the first thing to do. For me, as a periodontologist, of course, I am periodontologist and implantologist, not implantologist and periodontologist. Therefore, for me, what I was explaining to the patient, that first of all, we have to reconstruct to rebuild the soft tissue, in order to avoid problems later on, because we need to place there an implant in the 2-1, okay? And therefore you can see that we had a huge root resorption. Therefore we had the extraction was no question about the extraction, but you can see also that we have a very thin bone, and the cortical is missing. And just how to place there an implant with recession, with also the need of rebuild somehow this buccal cortical. And of course, my first choice was, before I did the extraction, I rebuilt, I covered recessions. I covered these multiple recessions. And you can see that this tissue, that it was around the 2-1, you could see that the huge recession there. And you can see 7 months after recession coverage and 3 weeks after the extraction of that tooth. Therefore, for me, it was the first soft tissue reconstruction. And afterwards, we get.
Sofia, just to ask, are the orthodontics also part of the treatment plan, or is that something else going on?
No, just because you could see, and I mentioned, maybe I was too fast. I mentioned at the beginning that the patient had a little high aesthetic demand. But the 2-1, the measure distal dimension was not the same when it was compared to the 1-1. That's why we had to open a little bit the space in order to have the same morphology of the two central incisors. That's why, exactly. and this orthodontic treatment was very, very short, but because it was to obtain the same, more or less the same distance. Therefore, you can see that in this situation, when I had in this situation, my soft tissue was mature enough to rebuild also the bone, to rebuild everything. Without this soft tissue, I cannot rebuild, I cannot stabilize anything, and to have this result that you have now here, you have a view after three and a half years, and okay, we have even more soft tissue around the implant that around the natural teeth, but is quite acceptable, and the clinical situation, the baseline was quite complex. Therefore, but even if it was quite complex, to go step by step to rebuild, to think, to anticipate what can be done and how you can avoid soft tissue recession, is, even if it is a little bit longer or even seems to be complex, I am repeating myself, is much, 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 much better, not only for you, for the patient to go like that, because with the thickness, you could see before the thickness of the transmucosal part that is extremely stable, and this thickness not only protect to protect everything, but protect also the implant itself, because we maintain the bone sound around this implant. Therefore, it's much better to go in this way to prevent. And the evaluation, thin phenotype, in this case were recession, thin phenotype, we have to rebuild bone, we have to, and if you do not pay attention to all of that, of course, at 3 or 4 or even 1 year, you have a soft tissue dehiscence.
Exactly. So what would you say is the most important lesson from this case that we take forward into other cases? To first, well, fix is not the right word, but first to draw attention to the soft tissue landscape before we move on with the implants?
Exactly. We have to, yes. Otherwise, it's so difficult to solve. Really, we have some clinical situations that are extremely difficult to solve if we want to save the implant, if we want to maintain the implant, because it's not only our decision, also the decision of the patient. And if the patient comes to us to have from us a solution, and when you are facing those cases, you have to find or to explant or to submerge. But there are situations that can be really, really, really complex because the patient wants to keep the implants.
Exactly. Now, thank you for sharing that case, and thank you for sharing the knowledge, for teaching us the difference between gingival recessions and soft tissue dehiscence. I'm pointing at my audience and saying, well, if you have been in doubt whether you would or would not submit your question, make sure you do it now, because we are slowly moving towards the end of this live EAO Just Ask as well. But not before, Sofia, I ask you, so tomorrow we walk back into our clinics. What do you hope our viewers tonight or our viewers in recording really take away from your message tonight? What do you hope they do different?
But the message is always the same, Gary. The evaluation, real clinical evaluation, to take into consideration all the anatomical factors that are really directly linked to the choice of the treatment. Just that, if we know how to evaluate, and just that, really, not to go, not because the patient wants to have an implant and everything must be fast. No, we have to take our time. We have to know how these differences not only have bone, but we have tissue, and how much we have to have of those tissue in order to be stable, in order to rebuild tissue, but how to stabilize that, and that knowledge must be really what we have to guide us. And if we do not know, of course, to go to search that knowledge somewhere. But for sure, the evaluation, the anatomical comprehension of the different clinical situations.
Yeah, that's very important. And so I hear you also say, not always let us be rushed by the patient, right? For a patient, it's always, not always, but it's often an urgent situation, right? And implants are the quick fix. Let's get them in and let's get it started. But if you plan for the long time, you might need to take a slower pace. Yeah, and you only know if you do a proper analysis. That's what I hear you say.
Exactly, a proper analysis, of course. Yeah.
Exactly, and you pointed us to the Zucchelli classification to actually as a little roadmap. So that's definitely some further reading that we are going to do.
I think so. I think that is really worth to read it.
Perfect. Well, thank you, Sofia. Now, don't leave yet, because I would like to invite you all to the EAO Congress in Geneva. It's coming up this fall, and if you haven't done so, you should register either sooner than later, because especially if you're an EAO member or considering EAO membership, let me point out to you that EAO members can still register for a significant discount if you do it this week. The deadline is June 15, so even if you watch this in recording, you might still be in time to benefit from the discounted rate. It's an exclusive rate of 290 euros for EAO members and only 100 euros for students. So if you are not a member yet, become a member today. And if you haven't registered for the EAO Congress this fall, then make sure you do that also as soon as possible. All the information can be found in the link right below this YouTube video.
Right.
In the meantime, I think that we are through our questions. Sofia, thank you so much for your time tonight, for sharing your knowledge and being prepared with us.
Thank you to you. Thank you for
you were a great leading expert in implantology, and thank you for all our active viewers tonight submitting your questions. Make sure you join us next month again for our next EAO Just Ask. And if you cannot get enough of these type of free education here on the EAO channel, make sure you hit the subscribe button on YouTube right now. You'll be the first to know when a new live session will be scheduled or when a new EAO video is published. And I'm looking forward to see you back on our next session next month. Bye-bye.
Bye-bye. Bye.